Good afternoon. My name is Calum Redpath, and most of you know who I am. I look forward to meeting those of you who I don't know later. I have no disclosures from industry, unfortunately, but I am happy to say I am. So, if you look at the university website, learning objectives are pyramidal in structure. Thanks for that, Ross. So I am going to ask you in typically bold Scottish parlance to modify your practice. And if you don't understand what I mean by that, by the end of the next 14 minutes, you will. I'm going to talk to you about three issues. One is the situation where patients who require devices are already on oral anticoagulants. I think that's probably the most likely scenario you'll face. Okay, we'll talk about elective and emergent procedures. What we see here in the Heart Institute, and those of you who work in emergent care situations, of course, are the patients who come in simultaneous. We heard from Derek earlier about acute coronary syndromes. I'm on service this week and I'm in the device clinic right now. And the idea is that there are patients who are coming in with their acute coronary syndromes or having had a septomyomectomy or requiring anticoagulation for some other reason, when within days they have a guideline indicated for anticoagulation. And the last thing I'm not really going to talk about, but I've put in the slideshow a nice little one-page A4 sheet setting of managing bleeding complications, because that's a significant concern for those who are doing this. So again, being Scottish, I'm going to tell you what I'm going to tell you. I'm going to tell you again. I'm going to tell you what I've told you, and then finally I'm going to summarise. So this is the number one message I want to tell you. Heparin is the devil's spawn, right? Dance with the devil if you please, but don't involve me and don't involve my patients. I don't like dancing. I'm not very good at it. Okay? I'm pleased to say that this is the number one study which has proven that this is the appropriate strategy to take. I'm pleased to tell you that we're the source of that study, and that's a shameless plug for my friend who's not here. Okay, it doesn't matter which subgroup you like. I'm not a fan of subgroup analysis, so the simple message is you don't need to use heparin. It just causes problems, and there is the figure there. An 85% reduction, or you can flip it on its head. If you use heparin, you're going to get 4 to 5 times as many hematomas. Okay, now why was the study powered to show hematoma? And because we didn't want to have to study tens of thousands of patients. We know that hematoma is actually a major deal. Now, those of us who deal with the devices all day don't need to be convinced of that, but perhaps those of you who are not familiar with it, is that, I have seen a patient of my own in another hospital some years ago, 34, previous stroke. She develops complete heart block. She's heparinized. The nurse gives a bolus instead of the infusion. Massive hematoma. The anticoagulation is discontinued over the weekend, and on Monday she's febrile and has a massive interest. Not only that, her device got infected, but to take the damn thing out as well. So we know that starting and stopping heparin or starting and stopping anticoagulation is worse than is worse than just leaving it on board, at least as far as Warfarin is concerned. So if you say to me, okay, well that's fine, but what about other situations, and you've not really addressed the concern as maybe we need heparin to strokes, right? Because you've told me that bleeding and hematomas are a problem. So here's a recent study, the Bridge study, a bigger study, 1,800 patients, all right? Bridging, this is in general surgery, not in device implantation. Bridging was not associated with a reduction in stroke or systemic embolism, but yet again it was associated with a 4 or 5-fold increase. You can see. All right, you say, okay, so what? But not everyone on anticoagulation is because of atrial fibrillation, which is a long-term prophylactic problem. What happens if these patients have had a recent VTE, right? And so they're on short-term anticoagulant and they come in as emergency, and you need to. This is a slightly different angle. So they really do need to remain on the warfarin, and their risk of recurrent VTE is very high. Within the first 90 days, the risk of recurrent VTE and death from pulmonary embolus is actually of the order of several %. That's an absolute risk, not a risk reduction, an absolute risk. Well, the simple answer is if you stop their warfarin and put them on heparin, you just get more bleeding. So there's a consensus statement by the Heart Rhythm Society. It's pretty clear. Risk of stroke and systemic embolism is 5%. Why have they used that? Because that was the inclusion criteria used in the BRUISE study. So David picked that because there is a significant concern that the bleeding risk versus the stroke risk in people who are extremely low risk of stroke. Remember, we might only be interrupting their anticoagulation for a week or 10 days, perhaps. So we had to take people who were at moderate or high risk. So that stroke risk of 5% was used as the cutoff. That's equivalent to a CHA2DS2-VASc of 3. Those in prosthetic heart valves, just leave them on their warfarin. If they're at extremely high risk of stroke, severe thrombophilia has not been studied, so that's an opinion piece. It's a position statement after all, not a guideline. Continue the oral anticoagulant. And essentially, we'll take the patient on as long as the INR is within the upper limit for their therapeutic indication. So 3 for almost all indications, 3.5 for the valves. And sometimes, if it's 3.1 and the patient's labile and there's a problem and, they're hemodynamically unstable, sometimes we just get a crud sandwich. Sometimes you've just got to. Okay? So my practice is, frankly, just keep the oral anticoagulant going. If they're extremely low risk, I put it to the patient, what do you want to do? Giving them the numbers, leave them on oral anticoagulant, or you can discontinue with nothing in between for a week. Actually, it doesn't happen very often. Hardly any of my patients have ever asked to discontinue warfarin altogether because of the hassle of getting started, stopped in the blood tests, and the absolute risk of significant bleeding on warfarin if they have a well-controlled INR is relatively low. And indeed, that's borne out by the studies which say if you ask patients what would they rather have, they're essentially, into summary, they're 4 times less unhappy having a bleeding event than a thromboembolic event. And that's pretty consistent regardless of the setting that the patients are asked in. What about antiplatelet drugs? Because, of course, lots of our patients are taking those. This is just a retrospective meta-analysis of a large registry whose name I've suddenly gone and forgotten. It's the BRNK Bridging Registry. It's a European Asian registry. And you can see that essentially anticoagulation continued. And this is real-world data, but it is retrospective, so it's subject to bias. But you can see that anticoagulation continued is not significantly different than anticoagulation held, or in patients who were on no therapy anyway. And we know that patients who have a guideline indication for warfarin turn up for devices and they're not taking warfarin. And it's less likely to cause problems than if they're taking aspirin or clopidogrel alone. And then we've heard earlier from Derek about the problem with dual antiplatelet therapy. And heparin-based bridging, frankly, is a nightmare. And you don't need to be a mathematician to work that out from this graph. So here's again a shameless plug. If you're on a NOAC, remember the BRUISE study was warfarin. If you're on a NOAC, please call us. We will enroll you in the BRUISE 2 study. I've got 2 patients from this morning's pacemaker clinic who are considering they're having elective device replacement. Because we need to know, is the same logic going to hold true for patients who are on? So remember, NOACS and device implant, right now there is no data. Okay, so in a vacuum, you can dance with the devil if you like, but not with me and not with my patients. Don't use heparin. The short-acting nature and the rapid onset of the novel oral anticoagulants are such that you can stop them. I've put in there a little mnemonic, but it's dead easy. If they have a renal function, for the 3 agents that are licensed in Canada, dabigatran, apixaban, and rivaroxaban, you just need to go D-1. So you just need to miss out 24 hours of treatment prior to the procedure. Essentially, in all of the studies, being hip or ankle surgeries or orthopedic surgery, vascular surgery, whether it's the licensing indicated studies for using the NOACS. There's been a lot with rivaroxaban. 24 hours hemostasis. You can. I often consider a short period of a dose reduction. So if they come to me with Bigatran 150, I often ask if they're prepared to take 110 for a period of time, and just as an attempt to try and reduce the chances of bleeding. Again, not based on any trial data whatsoever. I'm not pretending I know any more than anyone else. I'm just giving you my practice. Clearly, I'm recruiting for BRUISE 2, and I'd like to think that you would do the same. So there is a consensus statement regarding the role of antiplatelet drugs in device implant, but it's an evidence-free zone. That's what my because he's not my good friend, would call an evidence-free zone. Stephen Hawking. That's what he would call a black hole. And when you ever get a black hole, usually people fill it with opinions. So as has already happened, the consensus statement from the Heart Rhythm Society, based on absolutely no data whatsoever, has given us their opinion. And their opinion is consider stopping aspirin if possible, based on that the bridging registry I showed you earlier. That's not our current practice here in. What I do personally is, if you get the chance, so in an elective procedure, I always review, regardless of why the patient's coming to see me, is that patients often get put on dual antiplatelet therapy and they get discharged. And I wouldn't say they get forgotten about, clearly not if they're being followed up by my colleagues here in the Heart Institute, but sometimes the patients can get placed on these drugs and actually the guideline indication for them is gone. So I do try and assess, is the patient really needing to continue to take dual antiplatelets? Because obviously I want to stop clopidogrel at least. If possible, I'll even stop it and restart it. I won't do that without discussing without discussing with the cardiologist who recommended dual antiplatelets. We've heard earlier about this idea that if you have a second-generation stent, perhaps after 3 to 6 months, you could suspend treatment, but we would restart it. And then the last thing is that if the risk is high and the indication for a device is soft, or at least can be deferred, try and defer it. I have to tell you that in my experience, I just usually have to suck it up, and so does the patient. Just take Anecdotally, I will tell you that ticagrelor release does seem to make a mess of my operating table much more than clopidogrel does, but that could easily be subconscious bias. So I don't know if I've told you this before, but I don't think you should use heparin. So if you want to initiate anticoagulation in a patient who is awaiting their device, so this does happen, we see it all the time in CSICU, have been admitted with AF and bradycardia, and often, of course, what's people's first reaction? They'll start heparin. I think I've told you I would like to convince you that's not such a great idea. The NOACS are short-acting, so if you don't think the device is going to be implanted within 24 or 48 hours, you can start the NOAC and we can suspend it. Mind you, that's a recommendation based on ease of practice rather than guidelines or data, because we don't know what the right thing to do are. So we do know what to do with warfarin, and usually using a safe nomogram you might be able to start warfarin quickly. The idea being is whatever it is, please don't use heparin. We do have some data. There's been one registry application retrospectively, of course, using the HASBLED score. If you have a HASBLED score of 3 or more, it very nicely predicts the likelihood of bleeding in the short term. So my point being is that if you have a HASBLED score of 3 when you are deciding as a good physician whether or not to initiate anticoagulation, bleeding risk versus thrombosis risk, if the HASBLED score is 3, perhaps you could delay initiating anticoagulation until after the device is in. Remember, we're operating on the right side of the heart. Okay. Indeed, if you take the advice, if you take the old school advice of using heparin, we know that heparin compared to doing nothing, okay, does not seem to stroke or embolic events, but it does seem to increase bleeding risk. So we talk about bleeding a lot. Here is the one cheat sheet, which you should have laminated in your pockets if you're in the emergency room. I can summarize this very quickly. Whatever anticoagulation they're on, stop it. Okay. give them fluid. If they've recently taken the oral anticoagulant, particularly that's a NOAC, you can think about activated charcoal, you can think about fluid resuscitation, particularly the the pH of the urine is good with the dabigatran, and there are these now unpronounceable antidotes with you know, they should be hieroglyphics rather than words. I think if you just call up the thrombosis guys and say NOAC 2 hours ago, can I have whatever the hell it's called, they'll know what you're on about. Maybe you call it an antidote. That was less than 15 minutes. I would like my $1,000.